I also, at times, use my body to limit the amount of vision and increase the amount of orientation to the sensory stimulation. A lot of hands have to, you have to start the whole process with a lot of hands by bringing the hand into supination, and could you pass the pillow please? And supporting the hand on a pillow, because a low tone hand produces a stiff skeleton. A low tone hand produces a stiff skeleton. And the skeletal problems are not just hand, but they are radius and ulnar to hand. And so sometimes you have to support the hand in flexion to go in to vibrate the long flexor tendons to reduce the tension in the long flexor tendons so that you can actually get in to mobilize the hand. Okay, so vibration on flexor digitorum, superficialis, works very, very well to reduce the flexor tension in the arm. And then posturing the hand to come in to the flexor extensor musculature to mobilize it, mobilize it, mobilize it, mobilize it, to orientate the hand to the thumb producing the pronation and mobilizing the extensors, which also become thixotrophic, to produce a thumb that produces supination, where the pronation and supination is mediated maximally distally rather than proximally. So,
did you say that again?
yeah. So your first modality you would use would not be stretch mobilization. It would be reduce the tension through vibration. That would be your first modality. And then when you'd reduce the tension down through vibration, you would then look to mobilizing the flexor compartment, and then to activating through distraction the thumb to initiate the pronation, and then mobilizing through the extensor compartment to activate the thumb to produce the supination.
Yeah.
If you have a loss of stability, then my primary goal here is to reduce the flexor extensor co-contraction. If I was doing this differently, to go to the table, then I would lead the pronation and the supination through a stabilizing force through the abductor digiti minimi. So then I'm moving the radius around the ulna, and then I'm stabilizing the ulna to move the radius around the ulna. So I would do it differently if I was going into a grasp activity.
So it's activation as opposed to mobilisation is the difference. And the thumb doesn't give you, if you're going into pronation actively leading the thumb, it doesn't give you flexion.
Not if you're handling the thumb through the thenar eminence.
Right.
If you're not handling the thumb through the thenar eminence, it's very easy to get flexion. Yes. And you would get flexion of the thumb, you'd get flexion of the wrist, and you'd end up like that.
Yeah.
Yes. Yeah, that's a common problem. Yeah. So reduction of the whole flexor tension and co-contraction in the forearm allows you access to the carpal bones. And again, this is not worth practicing because you all have, I hope, and especially because you're therapists, you all have brilliant accessory movements in the hand. Otherwise, you wouldn't be able to shape your hand to your patients. But the low tone hand loses all its accessory movements. And you must get the accessory movements back before you start to voluntarily activate the hand. And so here you use your mobilization skills. You potentially might start at the medial aspect of the hand, at the thumb aspect of the hand, the radial aspect of the hand, keeping the medial aspect of the hand stable, and then you would alternate by keeping the lateral aspect of the hand stable and going for the medial aspect. And you will always find the greatest stiffness is in the lateral aspect. The greatest stiffness is in the lateral aspect. And then you may target certain carpal areas that have become very stiff, and they are usually down towards the radiocarpal joint. And one of the areas that is subject to a lot of problems is the radiocarpal joint. And we did this on Ruth and Jan's patient 3 days ago. The radiocarpal joint was stuck in flexion like this, and the flexor tension was high in the patient, and we stabilized the hand to move the radius up and into position rather than mobilize from the hand. So you always mobilize from the radius to get the position rather than flex and extend the hand.
I guess that's very common because
Very common.
I think lots of people I know would be like
Very,
that.
very common.
I think maybe dive into stretching too much.
Very common. So what we did was we put distraction onto his hand, having reduced the tension through vibration, and then we took the radius between my index and thumb, and we kept the distraction to get the mobilization. Back, forward, back, forward, back, forward, until we can get the range of selective rotation to get contactual hand. And that was immediately reflected in his improved contactual hand. So you want reduction of flexor tension, mobilization of co-contracting muscles, mobilization of accessory movements, specific mobilization of jammed up carpal bones, and then when you have the hand under your control, you then need to develop the pro and supination through the radial ulnar movement. And that gives you your baseline of contactual hand. And with your baseline of contactual hand, you can now start to stimulate.